Dr. Wachira. If you're on the tech team, please help me load Dr. Wachira's presentation. Meanwhile, let me have a 1-minute music intermission. Invite our first speaker, and I can promise you he's always looking good like he's on that photo. He's an obstetrician and gynecologist and the director of Savannah Healthcare Services. Ladies and gentlemen, help me welcome Dr. Wachira Morage. His global topic is causes and alternative treatments of infertility. Welcome, sir.
Madam Esther Saris, Women Rep, Nairobi County, the board of Fertility-Kenya, led by Madam Cecilia Karanja, fellow colleagues, doctors, other medical professionals, and other dignitaries, all protocols observed. Good evening, ladies and gentlemen. It is my pleasure today to stand before you, and before I start my short presentation, I do want to really appreciate Fertility-Kenya, an organization that I've been associated with for quite a long time, and single out Cecilia Karanja because of her bravery in coming out to tell her story, and from that story, from that single lady, she has blessed many, many people, children. She has given hope. She has come to squeeze us, please Daktari, operate this patient on my behalf free of charge. And she has done quite a lot. And I can see people, ladies are nodding. So with that, we can only say, may God bless you for the work you're doing, and we will continue supporting you. And of course, we'll be able to even get whatever support we get to enhance this noble activity that you're doing. So you've heard, my name is Wachira Morage. I'm a specialist obstetrician and fertility specialist. I work at Kenyatta National Hospital, and of course, as you can see on the screen, Savannah Hospital. And we have a CSR arm called Croton Health Foundation, where we are doing a bit of CSR, although ours is on non-communicable diseases. When I say that, apart from the animal you're having in the room about fertility, we have other diseases like heart diseases, cancer, that are really killing our people. And as chief medical specialist, because that is what I am, we are coming out to see, to lend a hand and see what we can do for our people. So let's go to our topic for today. I may need help with this. Okay, thank you. As a gynecologist, of course, I favor women, but I'll be touching on other causes of fertility in men. So that is infertility, that is the definition, and I'll run quite through because I know we are short of time. It's failure to conceive, so you're talking of about 1 year. So when you try to conceive for 1 year, that is when now we label someone to have infertility. And of course, you can see regular coitus without using any method of contraception. Infertility is divided into two. There is primary, for anyone who has never been pregnant in their lives. We have secondary. If you have ever been pregnant, whether you got an ectopic or you got an abortion, then you are said to have secondary infertility. Sterility is, of course, total inability to conceive, like the ladies who have had tubal ligation, or for the men who have had vasectomy. And then, of course, you have other very tough words there, fertility and fertility. Capacity to participate in production of a child, and the other one, of course, is the probability of conception. But the first two are very important because broadly that is where we lie. You have either been pregnant before or never been pregnant before. And the approach for the doctors will be very different depending on how they categorize it. How common is infertility? Our MC mentioned about 15%, but for the women we contribute to about 40%. For the men we contribute to 30%. 30% is shared, and of course overall. And sometimes we do believe as experts that the whole issue about infertility is underreported. We have 15 to 30% of the population, overall population. So that tells you that the issue of infertility is a global problem, and it is an issue that we need to bring our hands together as everybody to try and see how we can help our desperate couples also enjoy the gift of family. Next. There's one before that about causes. You can go behind a bit. Huh? Okay, let's go on. Okay, let's go back to evaluation. We will continue to get there. Okay, so when you come to the doctors, what do you expect from the doctors? That is infertility evaluation. So we expect that you give us a whole history about yourself, we will guide you, and most important, and just to mention, and for the men in the house, it's very important to accompany the ladies when you're coming to see us, because it really helps us, shortens the time for treatment, saves costs. When as men, we join the ladies to see the doctors when the issue is a fertility problem. So to determine the cause of infertility, and you're going to see the commonest causes. I won't bore you a lot, I'll just tell you the most common causes of infertility. To arrive at a prognosis, which is important for psychological implications. Remember, issues of not having a baby, not associated with a baby, it's a big problem and has psychological impact on couples and our women and men as well. And to serve the basis for treatment, that is therapy of infertility. Next. This one I just put it there to remind ourselves about the menstrual cycle as ladies and also men, how the cycle goes. You can see you have day 1 to 14, you have day 15 to 28. So that is how the menstrual cycle is, a normal menstrual cycle. And you're able to see that from your biology classes. Next. Good. Causes. I'm sure you are already asking ourselves, what are the causes? What are the common causes of infertility? Developmental. This is things that you are born with, we develop with. Some of us may not have a uterus. Some of us may miss ovaries. You may not have fallopian tubes, developmental, and other abnormalities. Endocrine is about hormones. That's why I put the menstrual cycle. If there's an imbalance, as commonly we refer to it, imbalance of hormones, there are things called PCOS, polycystic ovarian disease, that you produce abnormal hormones. Tubal factor, and tubal factor happens to be the commonest cause of infertility in this country. Infections. Not necessarily sexually transmitted infections. Infections from the private area. And we call them ascending infections because they just go up into the uterus, into the tubes, and when they cause inflammation, then they block the tubes. They can also block the uterine cavity where the baby stays. And uterine factors, things like uterine fibroids, things like polyps can also contribute to the formation of infertility. Next. So I'll just go through a few developmental, and I had mentioned a few. So you'll be shocked that sometimes you are born and you look good, but you may miss a uterus. that means you will not be able to have a baby. Uterine anomalies, you can have double uterus, sometimes you can have a single uterus going on one side. Gonadal dysgenesis, right? Some women are born and some men are born. The men do not have testicles, they have an empty bag. And for the ladies, they may miss even the ovary, or the ovary may be underdeveloped, and therefore it is not going to produce the much desired eggs. These are conditions: Turner syndrome, infertility syndrome, and chromosomal abnormalities. These are conditions that are associated with poor or absence of the reproductive organs, and therefore it means that the reproductive cycle is not going to happen. The hormones are not going to be there. The coordination, which is normally very intricate, is not going to happen. Next. A dot line is about hormones. You can see ovarian failure. You can see PCOS. I'm sure many of you know about polycystic ovarian disease, which sometimes affects our looks. Yeah, we may have some hair developing, we have acne developing, we may have a port, okay, and irregular menses, polycystic ovarian syndrome or disease, very common these days. Thyroid disturbances, adrenals above the kidney are also associated with endocrine causes of infertility. Next. Tubal factors: pelvic inflammatory disease, endometriosis, cornu or fibria. This is about infection. And what infection does is to destroy the organs. And once the organs are destroyed, then they tend to match together. And remember, the tube is a very, very thin organ. And once it's affected by those adhesions, then it tends to coil together. And remember, the tube is the area where fertilization occurs. There's ovum pickup from one side, and there's a section of the sperm into the tube, and that's where they meet. So if there's a block somewhere, then it means that there will be no fertilization. So by and large, the tubal factor is what we're struggling with because of the infections. Next. Uterine factors, myomas is a tough name for us for fibroids, polyps, and that condition they are called Asherman syndrome. Sometimes when we go in for washout, yeah, maybe we have an abortion or we have lost a pregnancy, and the doctors screen our uteruses, the uterine cavity can collapse, okay, and match together. That one is called Asherman syndrome, and it's a major cause of infertility. Next. Good. So when we want to do evaluation of infertility, and we are thinking of the tube, those are some of the investigations that we do. I know most of you ladies and the men know about HSG. Yes, that painful test that the doctors will insert some dye into the uterus, up to the tube. It's very painful. It's to localize if there's any blockage. It's for tubal patency, HSG. And those others, diagnostic laparoscopy. Now the gold standard of treatment of infertility cases. I can see Dr. Jackie looking at me and wondering whether I'll touch his page because he's a super specialist in laparoscopy. So it's the in thing now for treatment of things like even fibroids, things like ectopic pregnancy, cysts, and even the Asherman syndrome that we saw. Hysteroscopy, laparoscopy now is the gold standard, and is an art that the Kenyans now are developing. And there are a lot of training centers that have come up offering that. So take advantage. When you go see the doctors and you have issues of tubal blockage, don't just go for opening like a cesarean section. Ask for laparoscopy because it's a good technique. You heal very well. It's cosmetic because there are no big scars, and it also saves cost. Next. So that's how the fibroids look like. And I hope I'll not mess up our appetite. Okay, so that is a fibroid that is inside the uterus. You can see how it's really blocking. Right? Fibroid cavity. You can see it's like putting a stone inside the uterine cavity. Next. Next, please. That's how the fibroids look like, and that is a laparoscopy. You can see how the fibroid is hanging from the uterus. You can see the uterus, you can see the tubes on the side, and the fibroid hanging behind. Next. So how do we evaluate ovulation? This ovulation is defined, of course, as release of the ripened oocyte from the ovary, and there are hormones there that are listed for you to see. And of course, this hormone, which is very familiar with us, the anti-Mullerian hormone. This is the one that tells us, do we have enough egg reserve? Are we fit for IVF treatment? So that's how we evaluate the capacity of the ovary to give us good eggs for fertilization. Next. So what are the indicators of ovulation? How do we know that we are ovulating? The first term there is about pain. Okay, that syndrome is about pain. So there will be pain at a particular time of our cycle, especially the mid-cycle. Of course, there is the basal temperature. There is changes on the skin. You have cervical mucus, and if you go deeper into the lab, then you see changes in the vagina and also the cervix. Next. Management of the tube. What do we do as a surgeon? Because right from what you mentioned, if you go beyond what I mentioned today, then you go for IVF. These are some of the surgeries that we do on the tubes. Yes, so there is removal of those adhesions. Remember I said infection destroys the tubes. So it causes like cobwebs on the tubes. And then you operate those ones. And most of these ones are laparoscopic. So you have fibrinolysis, salpingoplasty, dissection and anastomosis. All those are operations. Before we can get to IVF, these are some operations, alternative operations that we can do. Because at the moment, and this is something Fertility-Kenya has taken in earnest to try and see whether we can get help. That's why we have Honorable Wachiras to take it up, that we do need the treatment for fertility to be taken up by the insurance companies, NHIF, the government has a policy to even take IVF, even to the mashinani. So those are some of the surgeries that we normally do before we now decide we are unable to give you a baby, and you proceed to IVF. Next. Okay, removal of fibroids, that is mammectomy, removal of polyps. You can do another a mini-invasive operation called hysteroscopy. You can also reconstruct the uterus. Remember I said developmental. Some ladies are born with abnormal uteruses. And you can actually operate to restructure the uterine cavities to remove abnormalities so that you are able to conceive. Next. And that is mammectomy, laparoscopy, do an operation to remove the fibroids. You can see the uterus has been opened, and that hook there is holding on the fibroid to try and check it out. And then after that, next, you repair. So all this is done through some holes, and I'm sure Dr. Jerry will be in hand to explain to us. Yeah, so you repair the uterus. Instead of opening, you can actually do it through holes. Next. Okay, you can use the same scopes. You don't have to open through the private area into the cervix and be able to see the fibroids right into the uterine cavity and indeed remove. So you can see technology has really come up in fertility treatment. Next. Hormonal treatment, all those are drugs that we shall tell you about. I'm sure many of you know about promethazine, the others, bromocriptine, aromatase inhibitors, all those are drugs. Next. That we use to moderate, because many times, as we said about hormonal treatment. You want to modulate the hormones, and therefore you use drugs. Still about ovulation, and these are things that we are going to tell you when you come to the hospital. We tell you the various areas that the hormones are deficient from, and therefore be able to modulate, be able to, to align the hormones for you to be able to get perfect ovulation and be able to conceive. We normally do this when we are sure that your tubes are okay, and when we are sure that our spouses, their sperms, the seminaries is perfect. That is when we go to those kind of treatment, the hormonal modulation. Next. Okay, prolactin. Remember hormone prolactin. All of us who are mothers know that when we are breastfeeding, we produce a lot of milk. Why do you do that? Because there is that hormone prolactin that stimulates our pituitary glands to produce the milk. All of us, even the men, have a bit of that hormone called prolactin. But in some ladies, they have excess prolactin, and that inhibits ovulation. And we have treatment for that. Next. Okay, these are other medications, metformin. I'm sure many of you have been given diabetic drugs to control ovulation. Yes, indeed, you just need to use a low dose because the issue of diabetic-like situation in the body inhibits ovulation, and therefore sometimes you use low dose anti-diabetic drugs to be able to align ovulation. Next. Clomiphene is a drug that we know, and it's used to invoke ovulation and helps in ladies who have some bit of ovarian failure. They're not able to produce eggs, and therefore we give them clomiphene citrate to be able to stimulate the ovaries to produce eggs. Next. Okay, those are other drugs, very tough names, but they do the same thing. We are talking about ovulation. Stimulating ovulation. There are ladies whose problem is they do not ovulate. They even have postmenopausal symptoms as young as 30 years. So an element of unexplained ovarian failure, and that is where such drugs come into play. Next. Okay, so still another drug, letrozole. I won't go into it. When you come over, we'll be able to give you the drugs. We have short protocol, we have long protocol. We'll explain to you because the explanation is very, very important. If you miss a widow period, then you have missed that period and you're supposed to be ovulating. Next. Thank you very much. I've just given you courses and alternative treatments for infertility. Thank you for listening.